Welcome back to another PCBH Corner. I'm David, joined by
Bridget.
And we've been having a fun morning all around. We woke up very motivated this morning to shoot some demo videos, to get in the clinic, get some work done. And we woke up to
our pipes freezing.
Yeah, plumbing issues. But either way, we can still shoot a PCBH Corner, and we're really excited about this one. And the first part that we wanted to express is just gratitude for people that are utilizing the listserv to ask questions and to prompt conversations. It's something that we enjoy reading, not only the questions, but people's responses. And it gives us ideas about, hey, maybe we should shoot a corner about that. So the recent one was about specifically a certain type of intervention or treatment. In this case, it was EMDR. Does it fit within PCBH? Does it fit within? And you responded on there and talked about, maybe looking at some barometers and some guidelines. And I was hoping that we can maybe explore that a little bit more. Like, how do you know if a clinical intervention is right for PCBH? Where's your mind go initially?
Yeah, I think that, and you had said this when we were talking previously, that it doesn't just go for, I think the specific question was about EMDR and PCBH, but as you and I have talked about previously, this can go for anything as far as blank space. Does that fit within PCBH?
Does a pathway fit? Does testing fit? Does implementing the new screener or some new initiative, does this fit? Yeah, exactly.
Yeah, does an initial or an intake, should that be 45 or 60 minutes versus the other more follow-up visits that maybe you want to be at 15 or 20 or 30 minutes. So whenever you're asking these questions of does blank fit within PCBH, I think
Can I pause you real quick?
Yes.
Remember where you're going. How cool is that? Because it really does make it less about, does EMDR fit? It's not about the specific intervention or the clinical thing. It's about primary care. It's what is the context of primary care? And does this align with those things? So I appreciate you saying that. So go ahead.
Yeah, so, and if folks are brand new to PCBH, if we remember back in the early
Back in the day.
Yeah, in the early 2010s, you're just trying to wrap your mind around, how do I take my skill set where I'm used to one certain context? How do I take that skill set and still have it be meaningful and now in this context? And so many times, as we've talked about before, that when you're talking about, can you do this in PCBH? Can you do that? The answer keeps being no, 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 no. And then it feels very restrictive. Whereas when I talk about PCBH, when you talk about PCBH, we get super excited because we think of it as being very expansive. All the things, whenever I'm thinking about PCBH, I'm always thinking about all the stuff you can get done. But sometimes the way it's talked about, and I get why it's talked about this way, it's talked about all the things that you can't do. But it leaves the person on the other end feeling
well, what can I do?
Well, what can I do? Or the point that you had made before about what if you find EMDR, for example, to be ridiculously valuable, or maybe psych testing is a huge part of your clinical identity. And now you're coming into this context, and every 2 seconds you're being told no. I think that you need a better answer behind yes or no than just memorizing it or an expert offering their opinion.
I love what you're saying so much, because it really does bring it to the light about one, what's going to make people feel good about their clinical work. We made that one PCBH Corner about the warm and fuzzies, and different things. What gives people the warm and fuzzies? And if you had someone that, as you said, was in EMDR, that was they really believed in it and stuff, immediately coming from it's can't do that. And it's my mind always goes well, why though? Why can't you do those? And that's where, as you were saying within your post that you made on the list, really it comes down to, is this part of Gather? Is this being a generalist? Is this being accessible, team-oriented, highly productive, or a high-impact educator or a routine part of healthcare? And is it part of the 4 C's of primary care? First contact, continuity of care, comprehensive care, and coordination of care. Does it align with those things? That's what we should be asking ourselves.
Yes.
In any way, shape, or form.
For all of them, like you were saying, prolonged exposure. Can you do that? Can you do some form of, cognitive processing therapy, EMDR, all these different things, family systems, and all the different work? I think that we're maybe asking the wrong question.
Love it so much. So let's get a little bit more granular in this. Like, what would be questions that people can ask? Like, hey, yeah, gather or 4Cs should be your beacon, should be the thing that you're going towards. Does this behavior help you get to those things? Like, I think that's a really great thing to be thinking about. My mind always goes to one of the more granular things to ask yourself, like, can you be interrupted while you're providing such intervention? So if there's a certain type of clinical intervention that you're doing, if there's a certain type of procedure or testing or whatever it might be, if it is something that you can't be interrupted for, I'm not saying that's dead on arrival. My mind says maybe be a little bit bold with it. It's probably dead on arrival within primary care because it limits your accessibility, it eliminates you being a team member, and it could maybe hinder even your high productivity aspect of this. If it is something you cannot get interrupted for, probably isn't a thing that is going to work very well within primary care.
Yeah, I think if you look at Gather, the biggest one that is constantly going to be the test, is that accessibility? It's just I feel like whenever different initiatives are brought up, or maybe we're doing consulting, or maybe I'm even thinking about something, I have to ask myself, is this going to take one of our team members off the floor? The minute something is taking somebody off the floor, that makes me very nervous. Now, we're not saying that there's not ways around things, which is why I think that it's too nuanced to just say like yes or no. Because in our system, we give everybody basically 10% time. So that means that with 10% of their time, they can do different initiatives. So if they weren't going to be on the floor anyways, and there's something that they wanted to maybe pilot or try, maybe they want to do, let's just use EMDR. Maybe they want to use a type of EMDR and it was during their admin time. Now, I'm not saying yes or no on that, because what if you start offering that and now it starts getting really specialized and now you're in clinic with all your other teammates and PCPs are asking for one certain thing? Well, now we're not aligning with being a generalist. And then depending on, again, I don't know enough about it to be speaking on it, but if it was an intervention where you need more time or you can't be interrupted, now other teammates want to get involved in it. Well, is that going to take them off the floor? And how's that going to, so it just keeps going down.
You can see how it ripple. The thing that I love that you said though was like, iterate it though. Like, come up with, and there's been some really great things that people have done with prolonged exposure and CPT within the primary care setting that has iterated these maybe more manualized like protocols and try to see like, hey, what aspects can really work within primary care?
And that's what folks put on the listserv.
Right.
So folks were talking about making the adjustments and saying, yeah, well, there's, this can work for this, and maybe you take pieces of it or skills of it. And I think that
pieces and skills. How cool is that? Like pieces and skills. Yeah, sorry, keep going.
Of that. And so it could render the situation with Gather as being accessible not that big of a deal, because maybe you're not off the floor and maybe you're not uninterruptible and maybe you're not just there either if you're a lone BHC being unavailable, or if you have other teammates and there's more than one BHC, they're not feeling like, oh my gosh, well, what are they doing in there again? Because I'm the one taking all the handoffs. I'm the one who's responding to all the requests. So
I love it, and I think that goes to another kind of granular kind of aspect of it, is that if an intervention starts to become something that, as you were saying before, that's targeting solely a specific population, and it's like we're gonna almost try to like specialize in this, that's where I would say probably for people, grace, love, and compassion, probably to pause on that, because that is now taking us away a little bit from the primary care mindset. We have that new kind of metaphor or quote now, if you were in a rural part of the United States and say there was no medical care that was started, say there was nothing, it's a town, small town, no medical care at all. The first thing when you go to set up healthcare in that rural town, you want it set up an endocrinology clinic, right? Like you want it set up a cardiology clinic. Like you would set up a primary care clinic. So because of the purpose of primary care meeting like the masses and trying to have a generalization of all the different healthcare things coming in, if we start to see our services more towards a specialty service, we probably need to pause a little bit more. It's like, oh, and the problem with that is that that's not saying there's not need out there for these other things that really need to be worked on. It's just saying like that's making us lose sight of what primary care is.
Which actually is a beautiful segue because I have two other concerns.
Ooh, yeah.
You know, we started off all politically correct, like, hey, you know, look it through your system, and if you can iterate something, and if you can still make something work, then go ahead and do it. I have two concerns with using. It's not just about using EMDR within PCBH and trauma. It's getting fixated on EMDR and PCBH. And one is this idea that we have to treat the trauma with a capital T, whereas we believe is that every single thing that you're doing from the minute you walk into the exam room with a patient, you should assume that folks are walking in with trauma.
Hardships, especially working in the settings that we work in, there's a ton and a lot of different suffering that people are going through for that. Yeah.
And back like some of our other videos of how to do interventions without doing interventions, it should be within your being. And so this kind of, I think, false dichotomy of like, oh, I'm treating trauma, I'm not treating trauma, or I had the first 3 visits, but now we're going to work on trauma. I kind of start getting some issues with that because the whole thing should be, so it makes me a little bit nervous when it's like, hey, I have this thing for this thing, because I think it should be more, dare we say, integrated than that.
I'm glad you went there. Because we've had these conversations with trainees that sometimes trainees might say, it's like, hey, I'm going to do some trauma work with someone. And again, it's well-intentioned. Again, grace, love, and compassion for everybody doing this. And we're not saying that we're right, just what our minds go to. My mind goes, it's like, I don't know what that means. Like, like you said, shouldn't everything that we be doing have a trauma-informed lens?
Yes.
Now, again, it's not to say that if a moment arises that, hey, prolonged exposure or some specific narrative work, or in this case, maybe some EMDR work might be useful for that moment, do it up. As you said, though, whenever we start to make these dichotomies, that it's like, oh, I'm working with this person, now we're going to do some trauma work. It's like, again, that just might lead us down some paths that we don't want to go down.
And as you just said, that like, hey, you know, you're working with them, and then you see a perfect opening for an EMDR skill to be utilized.
Pieces and skills, I love that.
Heck yeah, do it up, because you're going to still be being able to make it through gathering the 4 C's. Like it fits with it. You're not saying, hey, now I'm off the floor for this amount of time, or I can only work with this population. So if it's well integrated, then it's well integrated. So I have one more rebuttal for that.
And I have another one too. So go ahead. Do? Yes, I have another one too.
I wonder if it's the same as mine.
I know. That's what I'm going to just write mine down just to make sure. Okay.
All right. So, and maybe not rebuttal, the rumble that I have back with this is, out of all the skills and out of all the interventions that you can learn to work in a facile manner in PCBH, I just don't think EMDR is at the top of the list. I think getting a skill set in functional contextualism, focus, acceptance, commitment therapy, motivational interviewing, behaviorism, solution-focused brief therapy.
Did you say MI?
Yes.
Yeah, you said MI. Yep.
So that's where, if I'm going to have hours where I'm going to set aside for training, or and maybe you're actually in an internship where you provide the training, I'm going to want to start there. I'm going to want to start at something that is transdiagnostic, that you can get something done with. So if you're coming at solution-focused brief therapy, you can use that for anything, anyone, any condition. Fact and act is transdiagnostic. Motivational interviewing, transdiagnostic.
Behaviorism is relatively,
Absolutely, yes, absolutely. Yeah. So that's where I'm going to want to start. I think that you're going to get the biggest bang for your buck with the amount of upskilling that is necessary to be able to function well in PCBH. That's where I'm going to start. Now, if somebody's very facile in PCBH and they have this skill set and they're like, you know what, I want to just keep, increasing my skill set. I want some more tools in my tool belt. Then I think that's fantastic. Sure, learn about it, do it up. Now you got some skills in your back pocket. Absolutely. If it matches the other part that we had said earlier, which is the gathering the 4 C's. If it can match that, then we don't got no issue here. But we kind of do have an issue if you're brand new to the service, of all these other places you can start and get bigger bang for your buck.
I'm glad you said it. And again, please, obviously send emails, rumble back with us about that. My mind goes there too as well, is that making sure that if there are these specific interventions that we are doing, making sure that, I love how you said, Transdiagnostic should be our first thing. Like, what's going to get out to the most people with the most conditions? We should start there. That's without question. The second thing that comes out is like, what has the most evidence behind it as well? Like, we should probably start to have that to be a filter about like, hey, what has evidence? Prolonged exposure, CPT, not only does it have a pretty robust evidence base, it also has a decent evidence base within primary care as well. So it's kind of going through any type. We could switch out EMDR with any one of these things. It's like, what is going to be most transdiagnostic? What is going to have the most evidence base right now? What is going to be allow me not to be interrupted, allows me not to specialize, stays with primary care. And the last one I would say,
I want to know what you wrote down.
If it's something, and we've rumbled about this with people, and honestly, I bet some people are going to rumble with us back.
Am I going to rumble with you?
I don't think so.
Okay.
Anything that's going to say that we need to do a certain amount of visits just probably starts to lose, starts to erode a little bit within primary care. And the reason for that is that there's very, very few things that a PCP is going to say we need X amount of visits for. It is, let's see how this moment does, let's see how this intervention does, let's come back and check in on it. If it's not improving, we'll do something different. There's for sure times where, it's like, hey, we're going to set up some specific schedule due to a presenting concern, or maybe a medication that we need to do, that we need to check on, that we have so many visits. Largely though, any preset thing that's not based on a moment, that's based on a protocol, not saying can't work within primary care, it just starts to butt up against gather in the 4 C's and what primary care is.
Yeah, and I would say to check out some of our other videos as to why taking an approach of 4 C's and gather is important at baseline. Because if you're brand new, you might be like, well, why is gather and 4 C's so important? And so there's a lot of videos, there's a lot of evidence in the Robert Graham Center about when your primary care is well fortified, the health of communities ultimately go up.
So as we summarize this, regardless if it's an intervention, a pathway, testing, whatever it might be, first thing, filter it through, does it fit within primary care behavioral health? Gather, does it fit within primary care of the 4 C's? Getting a little bit more granular, again, is this something that you can be interrupted for? Does it make you more of a specialized approach to it? Does it have an evidence base? Is it transdiagnostic? Is it something that has a preset determined amount of visits to do that probably doesn't match up with primary care? There's a lot of different specific things that we can be asking ourselves. Is this something that works well here? And I would also say, as we talked about before, if we ever hit all the need of primary care, maybe we can start doing some of these other things that don't fit those boxes, right?
Right.
We're just never going to meet that need of primary care. So focusing on primary care and allowing that to be the guiding light.
I couldn't agree more with your summary. It was a really, really great summary. And just a few other little summarizing thoughts is just to not look at PCBH as a whole system as being completely restrictive. If you can innovate and if you can figure out how to stay within those parameters that we gave in an innovative way and having some ingenuity, then I wouldn't look at PCBH as being a restrictive thing. And that being said, now I'm going to talk out of two sides of my mouth because
that's what we do.
Because that's what we do. I'd go back to the argument of like your biggest bang for your buck. Amen. And there's other places that I think are going to be more fruitful right off the bat. But like we said, if all the conditions have been satisfied and you want more tools, and if it makes sense to do, and maybe it is a very small part of what you do, and maybe your team, like we're saying, is big enough to where you're able to use your 10% of the time where you weren't going to be in clinic anyways to trial something.
Test some things out, pilot some things.
There's no reason you can't pilot something, because I don't want PCBH to be marketed, and it already has been. I don't think it's any one person's fault or one organization's fault, but let's have it not be the model of what you can't do. Let's have it be a model of all the ways in which we can touch a lot of lives. And why don't we look at it through the lens of how can we touch the most lives as kind of our filter versus about being restrictive.
I really hope people made it through the video to get to that point. That was so well said. That got me so hyped. And when you think about iterations and innovations, isn't that what FACT was of ACT? It was taking something of ACT and being like, hey, let's iterate this. Let's try to get this out to the masses more. Let's embrace this idea that we only might have one visit with this person. And that's what FACT was born from. So thank you so much for, if you made it this far in the video, please let us know your thoughts. As always, rumble back with us. As always, thank you for stopping by, Bridget. That was great. That really got me hyped. So till next time.